All right, welcome back. We are starting now a new topic, which is actually the second step in the urine formation. Remember, first step of the urine formation was the filtration, which I allow the fluid to travel from the blood vessels, which are the glomerular capillaries, to my glomerular capsule or my Bowman's capsule. This is my very first step in the urine formation. The second step of the urine formation was to allow reabsorption, tubular reabsorption to take place. And tubular reabsorption is a selective process that allows all organic nutrients to get reabsorbed. Most of the water and ions will also be reabsorbed. It includes active and passive processes. There are two main routes for the reabsorption to take place, either transcellular, means the passage of the fluid and the solutes is taking place through the cell. So I'm passing from two plasma membranes, the apical side of the cell and the basal side of the cell. Or for some solutes, I'm traveling between the cells, and we call this as a paracellular transport. So either transcellular or paracellular transport. The main provider for the energy required for most of the reabsorption to take place is the reabsorption of the sodium. So if we're looking here at a peritubular capillary, the blood vessel on here, and this is one of my convoluted tubules, either distal convoluted or proximal convoluted tubule. The very first thing that we're going to be performing is the transport of the sodium. Transport of the sodium is going to be a secondary active process. So we're going to need here energy to allow the conduction of the sodium. But the energy that will be consumed is not only going to allow sodium to travel from the blood vessel to my from the tubules to my peritubular capillaries, from the filtrate on here to my blood, but will also allow an organic nutrient to travel with it. And this is what we call a co-transport or secondary active transport. Like, for example, the transport of glucose. So if I filter glucose out in the kidney tubules, the glucose is going to be transported along with the sodium by the same carrier, because this is a co-transport or a secondary active transport. As I move more sodium into the blood, now the concentration of sodium is going to be higher. And if you remember, who loves the sodium and will follow the sodium wherever it goes is going to be water. So water is going to be following the sodium by osmosis. And the water reabsorption going to be taking place through channels that we call aquaporine channels. So those are pores that will allow water to travel. Those are my aquaporine aquaporins or aquaporine channels. If I moved water back to my blood, what happens to the concentration of other solutes? So let's say if I did have, for example, calcium on both sides, equal concentrations of calcium. After I filter the blood, I did allow this water to follow the sodium. So here I added water to this side. So what happens to the concentration of the calcium in the blood as I reuptake the water back? What happens to the concentration of calcium? Or let me ask you the question in a different way. If you have a cup of coffee and you added water to it, what's going to happen to the concentration of the coffee? Will it become more or less concentrated? It will dilute. It's going to become less concentrated. So it's the same concept on here. Let's say I did have equal concentrations of calcium, but as I move the water from one side to the other, as the water follows the sodium, the blood gonna have lower concentrations now of calcium because I did add to it water. Compared to the kidney tubules, I dragged water out of them, so the concentration of calcium is gonna be higher in my kidney tubule. So what's gonna happen? Those will travel down their concentration gradient. Down the concentration gradient means from high concentration to the low concentration. Did you pay energy here for the calcium to travel or for a fat soluble substance to travel? Same exact concept. No. So I did pay for how many? I paid only for the transport of the sodium. And then the sodium will be transported along with an organic nutrient, like the glucose. As I move the sodium, water will move for free, osmosis. So you've got one for free, organic nutrient, another one for free, which is the water. And the third one that you get for free is going to be the cations and the fat soluble substance. You move them down their concentration gradient by diffusion. All right. Is this something logical? Is this something logical? To pay for one and get 5 back, 4 back? What do you think? Is this something logical? Yes, it makes perfect sense. Why? Because those, what you are reabsorbing did already exist in your blood. So it doesn't make any sense for me to pay for each one of them. So I want to minimize the amount of energy that I use to reabsorb stuff that I did already have. So the way I think of it is that a person did lose his phone. He just got a new phone and he lost it. And a person did call him asking him for $1,000 to give him his phone back. And the original price of this phone is $1,000. Would he be getting his phone back for the same amount like he first purchased it? What do you think? Would he pay the same amount another time? You don't have any personal stuff. You don't have like any important data that you want to keep. Would you pay the same amount? No, definitely not. But rather than getting a new phone for $1,000, you will make a deal with the guy. I will give you $200 for the phone, or I can simply block this phone and you won't be ever be and you won't be able to use it or sell it or do whatever thing with it. All right, so I pay the minimum I can to get the stuff that I already had. So you already had the glucose in your blood, you already had the sodium in the blood, you already have this water in the blood, you have the fat soluble substance, you have the calcium, you have the cations. It's not logical for you to pay for each one of them to get reabsorbed back. You want to minimize the energy expenditure here. All right, so looking at the reabsorption and secretions that will be taking place in the different parts of the kidney tubules. First is the proximal convoluted tubules. If you remember, the proximal convoluted tubules were performing most of the reabsorption. 65% of the sodium gets reabsorbed, which is going to be followed by water. 65% of the sodium and water are going to get reabsorbed just in the proximal convoluted tubules. All organic nutrients, all the glucose that you're going to be filtering, all the amino acids, everything going to be reabsorbed in here, in the proximal convoluted tubules. Loop of Henle, if you remember, I did have a descending limb, which is mainly formed of a thin segment, and the ascending limb, which had a thin segment and a thick segment. The descending limb is going to be formed of one row of flat cells, if you remember, and this is meant to allow free water reabsorption. So water will be traveling freely back to the blood from the descending limb of the loop of Henle. Ascending limb of the loop of Henle will allow reabsorption of sodium, secretion of some urea, like the rest of the kidney tubules. Looking at the distal convoluted tubules, what's very important to remember about the reabsorption that will be taking place in the distal convoluted tubules, that it's hormonally regulated. So it requires me to have a hormone in order to allow the reabsorption to take place. Like, for example, the sodium. Sodium requires you to have aldosterone. Calcium requires you to have PTH. So something very important to remember here about the reabsorption taking place in the distal convoluted tubules, that it's hormonally regulated. Moving on to our next part of the kidney tubules, this is going to be the collecting ducts. And remember, the collecting ducts is the place of action of the ADH. This is where the ADH, the anti-diuretic hormone, going to be allowing the reabsorption of the water back to the blood. All right, so our first question for the in-class activities for today. The blank cells of the juxtaglomerular apparatus secrete blank when blood pressure is low. What do you think? So blood pressure is low. What do you release from the juxtaglomerular apparatus? Do you release angiotensin 1, angiotensin 2, or angiotensin converting enzyme? Which one of the three? Or aldosterone? Which one? Which one do you release? Are you releasing angiotensin 1, Angiotensinogen, angiotensin 2, aldosterone. Which one? Released from the juxtaglomerular apparatus. Which one? Go back to your notes, check this out. Which one would you be releasing from juxtaglomerular apparatus? None of those, right? None of them. What you're going to be releasing is renin. And what is the type of cells located in the juxtaglomerular apparatus that did have granules, cytoplasmic granules containing renin? Those are my granular cells. So the good answer here is going to be B. Granular cells are the ones that would be releasing renin in response to low blood pressure. Moving on to our last step in the urine formation, which is going to be the tubular secretion. Tubular secretion is simply the reverse of the reabsorption. And those ions are the ones that we're going to be mainly concerned with secreting them. So like the potassium, hydrogen, or protons, creatinine, organic acids, substances that are bound to plasma proteins. Remember, plasma proteins are not going to be filtered. So if I've got a substance that is attached to a plasma protein, which is negatively charged or it has a large chemical structure, it won't get filtered. So I will need to actively secrete this substance out of my system. Tubular secretion is going to be the elimination of undesirable substances that have been passively reabsorbed. So if you remember here, during the reabsorption, calcium did pass back to the blood by diffusion because you did simply allow water to travel back to the blood. How about the urea, for example, or uric acid? It's still going to be the same concept. You're going to be creating a low concentration of urea back in your blood compared to what you already have in your kidney tubules. So some of the urea, some of the uric acid, some of the toxins will also going to be reabsorbed back by diffusion. Is this something that you want? Would you like to keep those toxins in your blood, or would you like to get rid of each one of them? I want to get rid of each one of them. So what we're going to do with those ones that got passively reabsorbed, I will be actively secreting them out. Other stuff that I want to secrete will be like any excess in the potassium, protons, and bicarbs in the urine. And if you notice on here, those are not stuff that I would be trying to get rid of all of them like the urea and uric acid. Here I'm not trying to get rid of all the potassiums that I have. Here I'm not trying to get rid of all the acids and bases that I have in the body, but I'm trying to regulate their concentrations to maintain a normal blood pH, normal chemical composition of the blood. So again, why do I need tubular secretion? First, to get rid of undesirable substances that got back from the kidney tubules to my blood by passive reabsorption, also stuff that you want to regulate their concentrations, ions, acids, and bases. You don't want to get rid of all of them, but you want to maintain normal concentrations in the blood. What happens if I drink too much water? If I drink too much water, what's going to happen to the concentration of the urine? Will it become more concentrated or less concentrated? Drink a lot of water. Drink a lot of water. It's going to be a dilute urine, right? So what happens to the color of the urine is going to become lighter in color, all right? So if I drink too much water, this is going to reduce the concentration of the urine. It's going to become dilute urine. How this takes place? This is my hypothalamus, this is my anterior pituitary gland, and this is a posterior pituitary gland, or the neurohypophysis. If you remember, I've got nerve cells coming down from the hypothalamus that are responsible to release a hormone from the posterior pituitary gland called ADH, or anti-diuretic hormone. If you remember, anti-diuretic hormone going to be acting on my collecting ducts. So those are my distal convoluted tubules, and this here is my collecting duct, like this. And this is my blood vessel. So if I drink too much water, I have an increase in the water intake beyond my needs. What's going to happen? This is going to be inhibiting the release of ADH. What was the function of ADH? Can you remind me? It prevents water loss in the urine, prevents diuresis by inserting channels that will allow the water to move back from the collecting ducts to my blood. This is a normal function of ADH. So if I have an increase in the water intake, what will I do? I inhibit the release of ADH. And so what's going to happen to this amount of water that I'm reabsorbing? It won't be reabsorbed back. And all this water going to be released out in the urine. All this water released out of the urine, out in the urine, this is going to be reducing the urine concentration, or what we call here the formation of dilute urine. All right, so again, if I have an increase in the intake of water, this is going to be reducing the release of ADH. And as I'm not releasing ADH, there will be no further water reabsorption to my blood, and all this water will be moving to the outside in the urine. How about concentrated urine? So if I'm not drinking enough water, what's going to happen? I have a drop in my pressure. This slight drop in the pressure will do what? Remember, will stimulate the granular cells to release renin that converts angiotensinogen into angiotensin 1, that will be converted into angiotensin 2. And angiotensin 2 was doing what to the ADH? It stimulates the hypothalamus and the posterior pituitary gland to release ADH. So what happens if I'm not drinking enough water? I have reduction in the water intake. This will directly stimulate the hypothalamus and posterior pituitary gland to release ADH. ADH is going to do what? It's going to be inserting the aquaporin channels in the tubular cells of the collecting ducts, and this will allow the water from, and this will prevent the water from being released out in the urine. Instead, this water going to be reabsorbed back to the blood. So what's going to happen to the urine that is moving out? Urine is going to become darker in color. Why? Because I am pulling water out. It's like as if I have a cup of coffee and I kept boiling the coffee. Over time, the water gets evaporated and the coffee will become much more concentrated. When you pull water out, the solution will become more concentrated. All right. In this condition here, the amount of water that gets reabsorbed if I have ADH released from the posterior pituitary gland, it's gonna be almost 99% of the waters that actually got filtered. So you see on here, if I'm releasing ADH, if I don't have enough water intake and I'm retaining all the water, trying to retain as much of the water as I can, 99% of the water will be reabsorbed. Questions? 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 All right, so moving on to the diuretics, and we're looking here at three types of diuretics. First one is the osmotic diuretics. If you remember, we mentioned earlier today the different pressures that will allow the filtration to take place. We did have a pushing force from the vessel that will allow the filtration. This is what we've called the glomerular hydrostatic pressure. And we did have two opposing forces, if you remember. We've got the hydrostatic pressure from the Bowman's capsule. This is my capsular hydrostatic pressure. And we've got another opposing force that would be pulling the fluid back to the blood, and this is what we've called the blood colloid osmotic pressure. Is there something I'm missing here? Is there something that I'm missing here? Is there any other force that I'm missing that will be affecting the filtration? What do you think? I have hydrostatic pressure on both sides. What is hydrostatic means is going to be determined by the presence of fluid. So do I have fluid in the capsule? Yes. Do I have fluid in the blood? Yeah. In the blood vessels? Yes. So both of them have hydrostatic pressure. And what did determine the presence of the osmotic pressure? Remember, the osmotic pressure is going to be present due to the presence of solutes. And remember, because of the presence of higher solutes in the blood vessels, those solutes are going to be pulling the water back to the vessel. But do you actually have solutes in your capsule? Do I have any solutes in here? What do you think? Do you have any solutes? that got filtered? Do you have any solutes? Yeah, I know that here I have blood cells, I've got plasma proteins, I've got macromolecules, those extra stuff that fail to get filtered. But do you have solutes that got filtered, or you're just filtering pure water? What do you think? Do you have any solutes in the capsular side? Do I have any solutes in here, in the fluid in here, in the filtrate? Should I wait for an answer? What do you think? What is the sodium that you're trying to reabsorb? What is the calcium? What is the sodium here? Glucose, amino acids, all those that you got reabsorbed. So all those were solutes in the filtrate, right? So my question again, do I have solutes in the capsule? Yes or no? Yes, definitely yes, definitely yes. Uric acid, urea, all those are solutes in the filtrate. So why I didn't mention the osmotic pressure that is created that's going to be pulling the water towards those solutes. If I do have solute, the solute going to be pulling water. Why I didn't mention the osmotic pressure of the capsule? If I do have solutes, those solutes going to definitely be pulling water. Why didn't I mention something that is called capsular osmotic pressure? Because simply it's negligible. It's so low to the extent that I do not consider it as an effective pressure normally. So again, do I actually have a capsular osmotic pressure that pulls the water towards my capsule from the blood? Yes, you do have it, but it's negligible. It doesn't present any weight, any effective weight in terms of filtration. That's why we neglected this pressure. But what if a person has diabetes? This is my Bowman's capsule. Those are my proximal convoluted tubules on here. My question, are you able to filter glucose? Can the glucose move from the blood to the Bowman's capsule? Yes or no? Can you filter glucose? Can you filter glucose normally? No. Yes, no. Do you filter glucose or not? Do you filter the glucose? Yes. What else? Who else? What do you think? Do you normally filter the glucose out from the blood into the Bowman's capsule? Yes, this is what we mentioned earlier, just a few minutes ago. Glucose gets reabsorbed. Means what? Means it's gonna be filtered in order to get reabsorbed, right? So do you filter the glucose? Yes or no? Again, for all who did respond, just confirmation that you get this. Do you filter glucose? Yes or no? Yes, you filter the glucose. Glucose is not a blood cell. It's not a plasma protein. It's not a macromolecule. It's nothing that can be filtered. So can I filter glucose? Yes, definitely it gets filtered. My second question, Do I normally get glucose out in the urine? What do you think? Normally, do I get glucose out in the urine? What do you think? So is it normal when you perform a urine analysis to find glucose in the urine? What do you think? No, no. Why? Because you're gonna reabsorb all the nutrients. All the glucose gonna get reabsorbed. Normally, you're gonna be reabsorbing 100% of the glucose back to your blood. All the glucose gonna get reabsorbed here. So would I have any glucose remaining to be released out in the urine? No, you don't. Normally, I'm not talking about diabetes or diabetic ketoacidosis. I'm talking here normally. Do I filter glucose? Yes or no? Yes, you filter glucose. Do you release the glucose out in the urine? No, you don't. What if a person has diabetes? What is the problem? The problem is that he has high sugar levels in the blood. So if I have high glucose in the blood, what do you think can happen to the amount that gets filtered? Would you have more glucose that gets filtered or less glucose that gets filtered? Or is it going to be the same amount? If I have high glucose levels in the blood, so this means more glucose is going to get filtered. And as more glucose gets filtered, what's going to happen? I will try my best to reabsorb all this glucose back. But the kidney tubules can't. The amount of glucose that gets filtered is going to be higher than the ability of the kidney tubules to allow 100% of the glucose to be reabsorbed. So what's going to happen? I will reabsorb as much as I can, but I would still have some glucose that I will fail to reabsorb. And this is the glucose that will be released out in the urine if a person has diabetes. So again, normally I have filtration of the glucose, but I don't have glucose in the urine. If a person is diabetic, at this point, he's gonna have high blood sugar levels. So this is gonna result in an increase in the amount of glucose that gets filtered. And as more glucose gets filtered, to the extent where it exceeds the ability of the kidney tubules to reabsorb, the part of the glucose that this person failed to reabsorb gonna be released out in the urine. So now I've got an extra solute that is not normally present. Normally, I shouldn't have glucose in the kidney tubules that remained. Now I have glucose. And this is my blood vessel. As I have solute in the kidney tubules, what will be pulled out following the solute? What follows the solute? Water. So the glucose that remained, because I failed to reabsorb it, because it was too high, gonna be pulling the water and it's gonna be released out in the urine. So patients with diabetes They will have polyuria, poly many urea. So I go to the restroom more frequently. I have extra water out. Why? Because simply this glucose that is located in the kidney tube is going to be putting the water out by osmosis. All right, so what do we call this type of diuretic? Yeah. A diuretic that applied an osmotic force to pull the water out. This is called osmotic diuretics. Another type of diuretics that we're looking at are the ADH inhibitors, and this is like alcohol. Remember, alcohol affects the brain, and part of the brain was the hypothalamus, which was responsible to secrete the ADH. So remember, alcohol inhibits brain functions, and one of the functions in the brain that will be inhibited is going to be the release of ADH. So when you're not releasing ADH, what's going to happen? Remember, if I'm not releasing ADH, there will be no water retention here. And as a result, water, rather than being reabsorbed, is going to get released out in the urine. So another type of diuretics that we see are the ADH inhibitors. A third type of diuretics that we're looking at today are the ones that will be inhibiting the sodium reabsorption. Remember, when I allow the sodium reabsorption, again, water gonna follow. So if I have a medication or a chemical like caffeine, for example, that inhibits aldosterone. Aldosterone function was to stimulate the sodium reabsorption. So if I taken caffeine, this is going to inhibit the aldosterone, and as I inhibit aldosterone, there will be no reabsorption of the sodium back in the distal convoluted tubules, and as no sodium reabsorption is taking place, no water will follow, and as no water follows, the water going to be traveling out in the urine. It won't be reabsorbed, and this is what we call a diuretic. So again, three main types of diuretics that we've seen. Osmotic diuretics, like in case of glucose in diabetic patients. ADH inhibitors like the alcohol, and the inhibitors of the sodium reabsorption like the caffeine. For second question for the in-class activity for today, the majority of the reabsorption takes place in which part here? Bowman's capsule, distal convoluted tubules, proximal convoluted tubule, thin segment of the loop of Henle, or the thick segment of the loop of Henle. Remember, where is most of the reabsorption is taking place? Remember, if you have a check, would you deposit it as soon as you get it or later? As soon as you get it. So you're going to be reabsorbing, reclaiming your ions, water, and organic nutrients back as early as you can. So you're going to be getting them back in the proximal convoluted tubules. And can you remind me, the majority of the secretion takes place where? Majority of secretion takes place in which part on here? Distal convoluted tubules. Distal convoluted tubules. Questions?